hysteroscopy in this group. Of course, Belen and Julia. So if you, who uses 3D ultrasound in the operating room? No. Okay. So I think we're constantly improving and evolving. So I think the addition of 3D in the operating room can be nice. So.
Keeping the ultrasound going during the case versus doing an ultrasound before, and then when you think you're done, like for a septum, checking, but not really, do you really need it during the entire resection of a septum if you're clearly seeing where you are?
It's a very good question. We do the ultrasound during all the surgery, but for difficult surgeries, and we do ultrasound, transabdominal ultrasound. And the 3D sonohysterography is for the volume, and we take the volume for 2 or 3 times in the surgery. It depends on the pathology. If we have, for example, a septate case, we use it several times because there's a big possibility of an incomplete resection. So we do it at the beginning to plan all the surgery, then, I don't know, 10 minutes later, it depends. And when the surgeon is tell us, okay, I think now it's complete, we say, stop, we have to check it and do it. So that's, I think, is the most important thing in this case. Several polyps, for example, you don't need an ultrasound guidance, but for cases of difficult hysteroscopies, it's necessary for good sleeping for the surgeon.
And if you see a good vascularity, how far do you go, or even on your pre-op evaluation in 3D, and you put on the Doppler and you see good flow up to a certain point? Do you feel like you need to resect the entire septum, or do you need to resect to the point of good blood supply?
Well, actually, we use the Doppler in just a little few cases.
We don't use it in operation room. We normally don't use it. The thing is, when we use it during the operation, it's quicker because when you are doing the surgery and if you have to stop doing the 3D reconstruction, usually we are.
No, I mean like ahead of time, if you see that there's good blood flow in a septum, and then during the surgery when you reach a point where you have good blood flow, do you stop if you have incomplete resection, or would you continue?
We stop there. Yeah. But normally what we see is the shape to control there is a complete resection of the septum, and to avoid another surgery or doing another sonohysterogram like 1 year after it, and you have not a complete septum, but you have already a partial septum, so you have to go in another surgery. So it will be a more accurate surgery when we do it that way.
Something. Your question was to see if we use Doppler to decide when to stop in the operating room. Right. Yes.
We do it more for, we look more for the morphology. Sometimes we look for the Doppler with the big septums. We don't have vasopressin, but what we normally use is we coagulate it. In one case, Juliana shows with a very
Coagulate.
thin electrode. We coagulate the vessel, and that's it.
We are quite aggressive with the resection. So even if it bleeds, we change from scissors to this monopolar cautery. We get the biggest vessels and we continue. Yeah. And then we block the bleeding, of course, that is a lot of bleeding, but usually they don't. And I think in this way, good preoperative preparation of the patient, like using either birth control pill or the Danatol for big septums, is good.
We make a transvaginal ultrasound also during operating and surgery to control the septum.
Hello, my name is Cristina Tănase Damian. I'm from Romania, and I'm an infertility specialist. I know it's an ultrasound course, but I would like to know your opinion about case number 5 from the presentation Uterine Evaluation by 3D Sonohysterography from Daniel Garcia. Was the uterus 1U1A from Escher classification, T-shaped uterus or dysmorphic uterus. I would like to know your opinion if you would go on hysteroscopy for incisions for a larger cavity. I know it's a controversial question. That's why I would like to know your opinion about. Some authors say no incisions, you don't touch the uterus. Others, every time they see a uterus like this, they go directly on hysteroscopy, and they say that have a lot of results after embryo transfers or, I don't know, spontaneous pregnancy. Thank you.
The thing is, I think that's the really good question about this type of malformation, what to do with it. The literature is not really clear what to do with the arcuate uterus, with the T uterus, with the septate uterus. 3 years ago, there was a paper that even septate uterus, they said they shouldn't be operated, I think. What we have to do, I think, is to all of us classify the uterus the same way, because we can have here a same uterus, and maybe we all classify it as a different thing. So if we do different studies, we can't use all this information to see if it's important or not. T-shaped uterus is very controversial to operate or not. I think it have to be depending on the patient, depending on the if it's very small uterus and you can make it bigger, maybe you can do it. But the information that we have today, there's not really an indication, and that's why the ASRM put it out of the classification. I think it shouldn't be that way, because it's a different uterus. It's not a normal uterus. You see that uterus, sometimes you see the ring inside the uterus. This is different and maybe has implication. But if you don't know and you don't classify this type of uterus, you won't know if you do something else, the result will be better or will be worse. I think T-shaped uterus, arcuate uterus, you can operate it or not, dependent on the case. Have recurrent pregnancy loss, maybe do it. Have a polyp, maybe you do the polyp and you do the T-shaped uterus. Depends on the patient, I think. But there's no really good information what to do in this type of patients.
I'm Ingrid Martinez. I'm gynecologist here in Tenerife, working more on ultrasound. And I would like to ask Dr. Rouleau, about the classifications on the malformations. If you, when you make your reports, if you use one of them, or if you use both of the because I mean we are more used to one of them, no, and to apply it in your clinic if you feel that one of them is more useful, or if you just inform both.
I really don't like neither of them. I think you have to be and improve on them. I work here in Europe. That's why I think if I work in Europe, I'm a member of ESRE. I'm a ESRE member, so I should use ESRE classification. And I try to use ESRE classification. I put the name of the uterus and try to do. And when I first saw this classification, I looked at very difficult to do it. But when you start to see, well, we first look for the uterus. U2, U1, U3, and after that we look to the cervix and the vagina, and we have the whole classification. I think it's a better way to do it. I try to put it in the when I do the report of the uterine malformation or a normal uterus, and the ASRM 2021 is, I think, is better than the other one, but I haven't used it. Maybe I will try to use it, because in this one you have to do the angle. We can practice how to do the angle in the when you do the practice part, and I will start to use it now, because this is really new. It's from last year, but now I use ESRE classification. We should use one of them. I think we, for now, use ESRE classification.
Thank you.
We are not, we didn't talk about TIME, the consensus of experts that measure the T shape and T uterus in a different way. So it's because you don't believe in them, or you know that and you don't want to use that because it's not a real consensus.
The thing is, we have this other classification. I didn't have time to put the three of them. The thing is that ESRE and SRM are the ones that are more like validated. Okay, if you see, you can look the two papers, the 2013 ESRE classification and the ASRM. It's a big work of why and experts they decide to do the classification that way. So I think it's very a good way of trying to do a good classification. And if we have a third one, I think it will be more complicated. So I think what it should be is to ESRE and ASRM both make one classification, and we go on all in this way and try to classify. Maybe they will think that T-shaped uterus is not important because it's the same, you have to operate it, but it's a different uterus, so you should get it into the classification. And then we will see if it's important to operate it or not. But if we don't have the classification, maybe 10 years from now we have another paper. It's important, but nobody have this uterus classification in their patients.
Thank you so much.